Yep. Okay.
All right. Hey, good afternoon. Welcome, everybody. We'd like to thank you for coming to DC Recovery's booth. We're here today with our afternoon panel session. I just wanted to say, my name is Mark Lassiter. I'm the executive director, and I wanted to thank everybody for being here today. And I want to thank our panelists that are here this afternoon, and also the ones that will be here with us tomorrow. Hope you're enjoying the Health Expo, and I hope you find our panel discussion this afternoon very interesting, as we know it will be. Thank you, and have a great time.
Thanks, Mark. I am Chris Powell, Recovery Coach Manager and Project Coordinator with DC Recovery Community Alliance, DC Recovery for short. We've had some great sessions earlier in the day. This is our cleanup session. Back in cleanup, we have some phenomenal people on the panel to go over a great topic that's pertinent to what we got going on today and what's happening in the world today. And so we're looking forward to getting into that. Want to remind everybody our theme this year is the show must go on, recover, renew, rejoice. And the essence of that theme is we know the show is going to go on no matter where you are in life or what phase of addiction you're in, but how is it going to go on? And what we came up with is we go on together. None of us can do this by ourselves, be it the individual or an organization. The main thing is that we unify together and help each other along this walk of recovery. So without any further ado, I'm going to jump right into the session. And the topic for this afternoon is the importance of recovery throughout the continuum of care, recovery during the pandemic, and its current state of the opioid epidemic. We found this to be very pertinent because before the pandemic happened, there was an opioid epidemic that we were really focused and concentrated on. But with the pandemic, closing the whole world down, basically, some of the other parts of healing in our nation, kind of got put on the back burner and really intensified, actually, because we all know in recovery that isolation is, the worst thing you can possibly do for a lot of folks, a lot of us in recovery. But the pandemic forced us to isolate, but then it also opened up some new avenues, as we can see. Look at us now. We're virtually getting to connect, and we're having a lot of people from across the country and across the globe connect with us virtually. So that is a positive thing. So even when the world opens back up, we'll have no excuse to be able to connect with our neighbors, across the nation and across the globe. So what I'm going to do next is I'm going to introduce our panelists and have them say a hello before we get into the questions. And we'll ask those of you that are in the audience that aren't quite on the panel just yet, just to hold your questions and comments to after the panelists give us a wealth of their knowledge and information on the subject, and then we'll get your insight and input thereafter. The first person I'm going to introduce is, he's one of the founders for DC Recovery. He has 39 years of personal recovery and leadership as a national advocate for addiction and recovery. He's a co-founder of Faces and Voices of Recovery and a former deputy commissioner of the DC mental health system. He's also a founding member of DC Recovery, which I already mentioned, but he's also established the Aquila Recovery Clinics, which is an outpatient recovery clinic that features integrated care. And I'd like to welcome back to our panel. He was on our first one, and it's such an honor and pleasure to have you back, Johnny.allem. How you doing, Johnny?
I'm doing fine. Thank you so much for the introduction. I'm getting old to have all those things behind my name, but anyway, this is an important occasion. We're not winning this battle right now. The disease is increasing exponentially, and we should learn from the opioid thing that working together we can change that. And working together means more than just people working together in this room. It means parts of the health system being coordinated to work together. And so I think that's how I see your topic there. And I'm looking forward to this session. Thanks so much for your work in leading this, Chris and Mark.
Thank you. Thanks, Johnny. The next person I want to introduce, she is the clinical director with Charles County Community Resource Center. She served as a liaison for workforce development in DC Recovery, as well as head up our anger management, co-occurring and double trouble sessions here at our POC. She's been phenomenal in our last sessions, and we're so grateful that she's come back for this third session that add her expertise to it. Welcome to the conversation again, Dr. Marquita Duverney. How you doing, Dr. Duverney?
I'm doing great. Thank you, Chris. Thank you for having me back. And yes, I kind of want to piggyback on what Johnny's saying, in terms of just really working together and making sure we're integrating these services across across the continuum. And I'll talk a little bit more about that as we move forward in today's discussion around co-occurring and how that looks in terms of the double trouble curriculum that we like to utilize in the trainings that we do. So thank you again.
Indeed. Thank you. And last but certainly not least, for 50 years, this next person has been a leader in the drug abuse prevention and treatment. He was the first director of the U.S. National Institute on Drug Abuse and the second White House drug chief. And he's also been a director of community services for the District of Columbia Department of Corrections. And he has served as an administrator of the District of Columbia Narcotics Treatment Administration. So it's such an honor and a pleasure to have with us today, Dr. Robert DuPont. How you doing today, Dr. DuPont?
I am thrilled to be here, honored to be here. It's an exciting moment for me. It's a homecoming. I started my career in the District of Columbia working for Walter Washington, and one of the finest people I ever worked with in my life. And I'm thrilled to be back. And the one concept I would just throw into the group is addiction tends to be contagious, but even more contagious is recovery. And I think it's really important to recognize the opportunity and the responsibility of people in recovery to pass that on to other people, because people in recovery are the inspiration for all the things that we are doing. They are the door into the release from chemical slavery of addiction, and it's exciting for me to be part of this program.
Indeed. Thank you. Thank you so much. Indeed. Well, we could jump right into the questions. I know you all have a wealth of knowledge that you're going to share with the group. And one of the first things that I wanted to ask was that, now with the peers being more accepted into the hospitals and into earlier parts of recovery, from prevention to harm reduction and into treatment, we know the peers have been here for a while on the recovery side and helping folks gain that sustainability. But one of the things that I asked myself was, from you all's experience in being in clinical settings and things like that, does a recovery-based approach work in the primary care setting? Bringing the peers closer, into treatment and things like that, what has been your experience and what have you seen as far as peers being able to be effective in the primary care setting? And we can start with you, Johnny.
My experience in the primary care setting is very mixed. I think it's a moving target. It's things we have to work on. But where we've been successful so far, particularly in, let's say, emergency rooms, is not so much what the system does, it's the attitude they have. And if they're getting, through the help of association with people in recovery, particularly peer support people, the staff in an emergency room takes a whole different attitude when they have a crisis that involves addiction. And they have somewhere to go. And it's not that they necessarily do so much, it's that they change their attitudes and they help refer people to the appropriate places. And when you get upstairs in the hospitals, in the behavioral health sections, they're more and more learning from their teachers and their science, the importance of co-occurring. And there is more work being done in people with emotional and trauma backgrounds and addiction. But it's a slow, steady progress, and you can almost go institution by institution, see major differences. But I can see in the last 5 years a real steady return in acceptance of some of these things. And without that acceptance, it may not be intentional prejudice, but it is prejudice. And that's what we've been facing all along.
Indeed. Thank you for that answer. And before I let the other panelists answer it, I'd like to welcome all of you that just entered the room. We're having a conversation about how things have been going with the pandemic and the opioid epidemic. And the first question I've asked the panelists is, does a recovery-based approach work in the primary care setting? And Johnny.allem gave an excellent answer. And I'm going to go to Dr. Duverney next to see what her take is on that.
Yeah, and just kind of piggybacking off of what Johnny was just sharing around, sometimes in terms of working with even, like you said, the emergency rooms and in the EMS system in and of itself, I've seen changes personally working in the community, how we were connecting clients, not just from, residential treatment, if they're having a crisis, to the emergency system into the hospital. It's less confrontational. And what do I mean by less confrontational? The discrimination, and I say discrimination because there is a level of discrimination when it comes to the stigma that's behind being in recovery, and really addressing that. And and in this world today, we're talking about diversity, inclusion, equity. Well, you have to look at it as a whole. Once you place a stigma or a label on an individual, you create that level of discrimination. So I'm seeing a different viewpoint in terms of looking at EMS systems, even looking at the police system. How locally in Hyattsville just a few days ago, you had a couple of police that actually de-escalated the situation at a gas station with a client, with a person who was apparently experiencing a social emotional concern or challenge. So I do see it slowly happening in terms of integration, but I think it takes the community to work on it, and it really takes the community to educate, not just educate themselves, but educate within the system of healthcare, as we move to break down some of these barriers around the labels and the stigma of addiction and mental wellness.
Thank you, Dr. Duverney. Dr. DuPont?
Yeah, I like to jump in and think about the bigger picture of healthcare in general and how it deals with addiction. And there's a real problem because so many physicians and others in healthcare have had so many disappointments of working with people who are addicted to drugs, and they have a pretty negative attitude about the likelihood of them getting clean and sober. So there's a kind of pessimism involved in that. And this is where the recovery community can make a huge difference. I think in primary care and everywhere else, physicians need to understand, they need to first of all be exposed themselves to people in recovery. They need to talk to people in recovery. They need to understand how it's possible because they see so many frustrating experiences, they don't think that's even possible. And to talk to, so having them get into contact with recovery is important, but it's also helpful to have them get their patients into contact with people in recovery. So that it's not just go to treatment, it's get engaged with the process of recovery. And the sooner that happens and the more it's sustained, not just for the individual patient, but for the family members also. So they understand, what is this disease? How do you get well from it? How do you stay well? And that it is possible, no matter how awful the situation is, no matter how many years it's gone on, it's possible. And that has to do with exposing people who are demoralized by the defeats they've had in dealing with addiction, to see that there's an other side to this, and there is hope, and that it is really exciting to be able to connect people to that recovery community.
Awesome. Great answers. Great answers. Well, now that brings me to this next question, because we have seen that, like with the pandemic being taken over the world, my question is, how has the pandemic affected your approach to recovery, and what have you seen the client's experience been? I know because there's only been a year and it's very new, but I'm sure you can see, some effects and some changes. Of course, there's been a lot more suffering with our people in recovery because of the isolation. We know drug sales have gone up and alcohol has gone up, but has it changed your approach, or what have you seen, since the pandemic in terms of us addressing this? What's your experience been? Thank you. Johnny?
Yeah, I'll have to build on that and say one thing that we've been realizing in this epidemic, the COVID epidemic, is this tension between science and hearsay and prejudice.
Yeah.
And that's a lesson in it for us, because that's the same wall we have to overcome. When there's nobody around to represent recovery, people stay in their old patterns and their old prejudices and think of it as a moral sin and all that sort of thing. When they see evidence of it, they can move pretty quickly. And we have to be very science-driven. And I think that's important. I wanted to say that there's nobody better than Bob, and goes back all the way to the 70s, being a leading scientist in this field and been a friend and fighter for all of us all that time. But this is a pretty nice read, but it gives you that history And I just think that we need to say, just like Dr. Fauci says about the COVID, science is the key to bring us all together and to see progress instead of that 21 million people every year. They're in addiction, only 10% of them getting help.
Yeah.
Most certainly. I would definitely agree with that. And that is an excellent resource that Dr. DuPont has created for us. And we encourage all those that are in the room to come to our website and go to our YouTube channel, where there's another conversation with Dr. DuPont and Johnny.allem, and where we're looking to feature those books as well, because we want to get that information into as many hands as we possibly can, because it's definitely an excellent resource. So Dr. Duverney, what has your experience been during the pandemic as far as addressing the epidemic? We got so many mix going on. It seems like pandemic, epidemic. I don't want to get tongue tied, but what's your experience been throughout it?
And it also all cross. I just speak from working in the environment, even in a residential treatment facility. Actually, what we saw, and I thought I was actually very surprised, is that clients were actually coming to the facility because they sought it out as a safe place. Because we had set requirements to come in. And we were one of the few agencies in the community at that time that set some standards around, coming in, getting tested, getting screening. And it's not so much tested for the COVID, it was just making sure that you're looking at the physical health and well-being of a person. So generally, when you're coming in, you're getting those general health tests, you're getting the temperature checks, you're getting the TB tests, you're getting things like that. But also the environment in and of itself was cleaned. And we had a standard where we clean the environment daily. And so what we saw early on this time last year, going into April and May, is that consumers were actually coming in and they were actually motivated by COVID to come in. And so we really looked at that. And then on the other side, something in terms of science that you all mentioned earlier, Johnny and Robert, we were looking at, how that stigma was laid upon COVID even early on as well, how people were afraid to admit that they had been exposed to COVID, and how they, looking at stigma, even of addiction, how they shied away from treatment. So, when you really look at a label or a term, and I got to purchase that book, Chemical Slavery, it is placed on an individual because there is an unknown, and there becomes that perception of what people assume is going to be, or what they assume should be. And so I saw even COVID early on looking like an addiction in terms of the stigma that was labeled for those persons that were testing positive, and there was no quote unquote treatment for it at the time. So I kind of saw, both sides, being in the field and working in the community, but also looking at it from the science side and teaching at Bowie State University and having those conversations with my students when we went online this time last year. That was part of those conversations that we were having.
Right.
Great. Thank you for that answer. And as you said that, I was starting to, because here at DC Recovery, we focus primarily on the recovery side. So we've been educated to a degree, like the phases of addiction and sort of stages of change. So we know, so as peers know, as they engage with the clients, they'll know what they're going through from a technical aspect, even though they know just because of their own experience. So they can, they definitely relate right away as they get with the client. But something that was coming to my mind now was that as peers, it may be beneficial for us to understand, are there different stages of treatment? Because I've heard of like stages of recovery and phases of addiction. Is there like stages that a person goes through in treatment that would be informative for us that are more so on the recovery end that may be beneficial? Are there different stages, or is it, help me out, just so I can understand as a recovery coach how to approach? And any of you could answer. Indeed.
Can I say something about that too?
Yes.
Follow up about, this word recovery can mean a lot of different things. You can talk about recovering from tuberculosis, for example, or recovering from cancer. And that's not like recovering from addiction. With a cancer or tuberculosis, the disease goes away and you go back to where you were before. That's not, this is the only disease where in recovery, you're better than you were before. It's better than well. And there's a kind of arrogance about treatment, the idea that somehow treatment is going to fix people. Treatment doesn't fix anybody. What treatment does is put people on a path to recovery. It's a very important step, and it's a very important step for lots and lots of people. And treatment is wonderful. I spent my life in treatment, so I believe in it. But it is not the end of the game. It goes on after that, and recovery is a process. And the most important thing to me to get straight is it means stopping using drugs. It means stopping using alcohol. It means stopping using marijuana. It's not, you talk about opioids, and the treatment is not just not using the opioids. It's not using any drugs. That's the first step, sobriety. So there's a sobriety date, a time when you stop. It's really important to the concept of recovery. And it needs to be maintained over time. It's not something you're done with. It's a process, a lifetime process. And honestly, when we use the word, I think it's awful easy for people to hear it as being, oh, it's like cancer or it's like heart disease. It isn't like that. It's something quite different. Another thing I say, there's more wrong with a person who is using drugs than that they're using, and there's more right about a person in recovery than that they're not using. This is a disease of the character as well as the brain, and it's really important to understand that, because I think a lot of people who are viewing us maybe don't think about it, that this is not like those other diseases, and it's more hopeful. It's not more difficult, it's more hopeful because of the outcome of it.
Yeah, and I'm wondering, Dr. DuPont, do you think that perhaps, because I know when I started learning about recovery, people because they wanted folks to take it so seriously, they wanted folks to start to think of it in those terms of, like, say, a diabetes or cancer and things like that, so they could take it more seriously. We lumped it, we pushed it so far over there that we haven't made the distinctions that you're talking about.
Well, and also, I started with methadone treatment, which was very controversial. And the idea that somehow it was methadone was like insulin for diabetes, and the person takes methadone, and that's the end of the story. You just take it for the rest of your life. Well, it didn't work out that way, because people left the methadone program and went back to the drugs the way they don't do with insulin, and because there was more involved than just not using in that. And I think that I'm all for medication. I'm not against it, but that's not the end of the game. It's not like insulin and diabetes. There's more to it than that. And I think that really is important to get it clear. Yes, it is a biological disease. It has to do with what the drugs do to the brain. They hijack the brain. When you're talking to somebody who's using drugs, you're talking to the drug, not to the person, because of what the drug does. It changes the thinking of the person. And just like that, a person in recovery has thinking that's entirely different from that person. And that to me is what's really important for people to understand and get to know. I mean, to tell one story quickly, and then I'm going to shut up for a while. But when I started this program in Washington in 1970, February 18th, 1970, we treated 15,000 heroin addicts in the city in the next 3 years. It was a very big deal. And I had a group of ex-addict advisors who were my best buddies in doing what we were doing. They were people who had been heroin addicts earlier, like Ron Clark was in that era, that same cohort that he was in. And one of them was Napoleon Turnell. Some of you know him. He was a very famous guy in Washington, a wonderful person. And I went to his retirement party when he left the government job he had. And I asked about the other guys, and they were all dead. And I said, what happened to them? I figured they went back to heroin. Not a one of them went back to heroin. They had all died of alcoholism. They had all died of alcoholism. And it was horrible what had happened. And I said to Napoleon Turner, and he wasn't my patient, so I'm not talking about a patient. He was my friend. I said, Nap, how come you're alive and they're dead? And he said, oh, Bob, that's very simple. What is it, Nap? I went to AA meetings and they didn't. Boom. That had a profound effect on me, what that story was. That really meant a lot to me, and it changed the way I think about this disease.
Thank you. That's incredible. That's truly incredible. I have a question that was in the chat, and I think I may know the answer to this, but and I'll start with Dr. Duverney. but the question was, is recovery possible, and how do we connect communities with the critical and needed resources to address the social determinants of health? So when the first question is recovery possible, and I think I may know the answer to that, but not, and how do we connect communities with the critical and needed resources to address the social determinants of health?
So yeah, and then I'm going to let you answer that. So yes, recovery is possible. And I am a true believer in this also. When a person walks through the door, that's the conversation you have when they first walk through the door, because you have to have a purpose for coming in. The purpose is because you want to be in recovery. Now, it's a path. Absolutely, it's a path that starts somewhere. And I think part of what I'm seeing over time is, you know, we sometimes we preach the story, you're coming into treatment. But you're coming into treatment because you want recovery. And I think that's a conversation that we need to start having so that persons can move into addressing those social determinants, right? Because coming into recovery, as we were talking in our earlier session, you're looking at the holistic person, and the holistic person is part of what is it that the continuum of care for recovery, what needs to be in place to support the whole person and not just part of the person. And again, my hand is the appendage. Here is the core of the person. But then that person has all these other pieces that happen around them to be in recovery. And as we talked about, housing, food, employment, these are things that build up the person, and it focuses on not only their self-esteem, but, you know, the basic laws of hierarchy of needs. What does a person need to survive in a community? I don't just need to be sitting on the street. I need to be connected to services. And this is just what Dr. DuPont was speaking about and Johnny was speaking about. It's about a connection. Not only are we going to connect with people within us, but we have to connect to those services outside of us. And how does that happen? And being an advocate of the community, the services are there, but I think part of our role as advocates are to make sure that we create the linkages. And you spoke about that when we were talking about emergency rooms, you know, peer specialists being in the emergency rooms and connecting their peers into the community, tapping into those services that support the social determinants, right? And those social determinants are what we need to survive as human beings.
Indeed. Thank you so much. Johnny, did you want to take a stab at that as well?
Pretty good job as far as
I hear you. Indeed. So let's see.
Big picture of health has got to include the whole thing. And when we say co-occurring disorders, we're mainly talking about mental health issues and addiction. But that's just the beginning. Overeating, pressures in life, getting a good education, all the things that Marquita mentioned are part of life, and they're part of a good life. And if people don't have a taste for that, or they don't have ambition for it, we need to stimulate that ambition to where they want a whole life. Because it's all related, just like we're all related to other people, these issues are all related to our overall health.
As I was sitting here, I was thinking it because this is very informative, and a friend of mine, he always says what comes from the heart speaks to the heart. So I guess I wanted to get from you all, and Dr. DuPont, you shared a great story, what impacted you, and I guess I'll ask Johnny, and I feel like I may have heard him say some things in the past, but what drew you to this work? Like, why is it so passionate for you, and why does it mean so much to you?
Well, it turned my life around, and I didn't know where I was going to go with it. When I got sober, I opened a print shop on 13th Street just to get off the road. I had been running political campaigns for 20 years, and most of that time drunk. And but it's the same. My life was on pause for a minute while I figured out what to do, and things kind of came to me. And being in the public communication business like I was, PR, I felt that there needed to be a better understanding by the public of our disease. So much of my life, and even beginning when I was I didn't ever plan to make a career. I figured I'd have a job, and this would be my passion. But after a while, the passion took over everything. But I was working in the mayor's office in that same period of time. And then got down into Department of Mental Health. And in those days, you know, the addiction care was in the Department of Health. It wasn't in mental health. And some of us were fighting for that merger for a long time to come. It didn't come on until about 10 or 11 years ago. But I was fighting back then for things that I knew would get people well. I'm the one that brought co-occurring treatments to DDC to 170 clinicians, both in APR and in the health department. I was active mainly as a hobby or as my passion. I had a regular job to do, but sooner or later I really felt called to be more directly in the business. The volunteer part, I was still I helped form two AA clubs in the district, and like somebody mentioned, Jim Vance was my partner on one of those things, and in the formation of a national movement, in the month following 9/11, we formed in St. Paul, Minnesota, the Faces and Voices of Recovery, and that's now organized like 200 groups like DCRCA is in District of Columbia. Now, I think that a small part I played in that is one of the most important things that happened, because it brought voices to people in recovery that they could share and tell their stories without being embarrassed, being fulfilled in doing it, and knowing they have a right to do it, just the same as somebody who's recovered from cancer or any other illness. And so that just kept me more and more centered. I was retiring, I think the third time, but I was 71, and that's when I began to see treatment in a different light. I didn't see treatment as really having a holistic view it should have, having co-occurring, having enough time to work it out. And the clinic I started 11 years ago was the first one that I know of anywhere outpatient. It had a 16-week regimen. We had 6 weeks of IOP and 10 weeks of OP. And then we let people stay for as long as they wanted to under CP, continuing care, to treat special issues that had come up and cropped up. And maybe at the beginning, they didn't even have an awareness that they had this need. But after 16 weeks, they say, yeah, I want to work further on this issue. And that's been very, very successful. As the outcomes that we get from research are very, very significant when you take that view. And so I preach that view wherever I go, and a lot of other treatment center friends I have around the country have expanded their number of weeks involved. I've gone to co-occurring formats a lot. I've been watching that happen in the last 10 years as we do it here as well. But that's my passion, and I'll keep it the road as long as I can stay.
Indeed. I'm thankful for it. Dr. DuPont, I remember, well, the story you told us, I see how it impacted you. What you can either answer what made you so passionate about it, or what's keeping you driving, what keeps you going today as far as doing this work.
You know, thank you for asking that. When I was a resident in psychiatry, I worked 1 day a week in a state prison in Massachusetts. That was the state prison where Malcolm X served his time. It was a very famous prison, and I was very caught up in the civil rights movement also at that time. I went off and spent a year traveling in Africa during my residency, and I carried with me a letter from Martin Luther King Jr. introducing me to the continent of Africa, because I'd met him in Atlanta and knew him from working with him. So when he died, part of me died also. But I really cared about the people who were in prison, and that was what I devoted my career to. And I got into drugs because of the drugs having such an important part of getting people into prison. And the embarrassing thing to me about my career, and I'm sure there's lots of other things I should be more embarrassed about it too, was it took me 20 years in the field to understand about recovery. I didn't get it. I really didn't understand it. And how I did get it was from my patients. I've had my own patients all this time, and I watched people get in recovery and get better than well. And I've become quite an advocate for that. But it was from my patients that it happened. And as I say, they have been my best teachers all through these 52 years.
Awesome, awesome. Dr. Duverney, what drives you today, or how did you become so passionate about this work?
My father, actually, he was in the Vietnam War, and I'm the middle child, and I was the one that he kind of leaned on. You know, I was young, right? And I couldn't understand the yelling, the late night yelling, the screaming late night, because my bedroom was right next to my parents, with my sister and brother across the hall. I couldn't understand the late night yelling. And so as he got older and I got older, he and I would have conversations, and he would have conversations about what he experienced in Vietnam. And then at that time, we're talking the late 60s, 70s, and early 80s. My father passed away 20 years ago next week from Agent Orange. But what I learned was they weren't treating veterans coming back from the war. And so it's sort of that self-medicated. His choice of drink vodka and King cigarettes, right? All day, every day. He was quiet, he withdrew, but I was the only child that he would actually have lengthy conversations with, even up until he died. I ended up having to move home for 4 years from DC because he wouldn't allow my mother to pay bills, my sister or my brother, do anything with the house. And so I had to go and help my mother be his caretaker. But when you talk about the stories and the visions that he was having, the post-traumatic stress that he was experiencing, and his only outlet was vodka, was the cigarettes. I mean, he had jobs here and there. My father retired as a CW. He flew airplanes in the war. He was trained by the Tuskegee Airmen at 17, right? Coming out of high school. And was rewarded recently, posthumously, several years ago at the military base, where he actually created the EEOC program. He created all these programs, but he couldn't find a job. And part of his finding a job was the alcoholism, and I think the withdrawal, the PTSD that he had, and he had no outlet for it. So my conversations with him, and I think my conversations became more anger towards myself. And so when I came into the field of social work and counseling, I chose to work with children. My first 15 years, I worked with early Head Start here in the county, in Prince George's County, Maryland. But in 2011, I had an opportunity to go to SAMHSA and I actually ended up in CSAT. I hated substance use. I hated addictions because of what I saw my father go through. But since 2011, my passion has been to work in the field. And it's not just working in the field, because who at age 48 goes into the government and comes out, right? But I wanted to be back on the ground. I want to be back in the community because I felt by being back in the community, I felt like I can give more. And maybe that's not always true. But for me, my passion said to me, I needed to touch the people. I had wonderful experiences at the federal government. I had a chance to travel across the country to territories. The cultural impact in communities different than ours, in the non-Western communities like the Indian communities, was amazing. That experience was amazing in terms of how they culturally treat their community, in contrary to the Western society. So my experience and my exposure, even working those 3.5 years, was what brought me back to the community. And my passion has been here since 2011. And here we are 10 years later. And I can't give it up. I enjoy it, from the children to the adults and so on and so forth. So I'm the advocate that has a passion coming from a family-driven experience that still stays with me today, because my father is my angel today.
Beautiful. Awesome. Beautiful. Indeed. I thought somebody had to say something. Okay. I do have a question in the chat, and thank you, Ms. Walker, for putting it out here. It says, what are the top 2 to 3 things that a person outside the treatment profession can do to support the efforts of a recovery clinicians, practitioners, meaning what avenues of advocacy have proven to be most helpful? For those, the top 2 to 3 things that a person outside the treatment profession can do to support the efforts of recovery. Avenues of advocacy that have proven to be most helpful. And I'll leave that open to whoever wants to give it a shot.
I think about what you can do to support the programs, the treatment programs, and the other prevention programs in the community. One of my passions now is prevention, because addiction is a pediatric onset illness. 9 out of 10 people began their use during adolescence before the age of 18, and the adolescent brain is particularly vulnerable to addiction. When the earlier people start, the more likely they are to have a long-term addiction problem. So to me, one of the great things to do is to have fewer people being addicted by helping people grow up without using drugs. People don't realize that in the last 40 years, there's been an increasing percentage of American youth who don't use drugs. And it's kind of interesting. We've done the research on that, and you all might be especially interested in the fact that we had in 1983, 3% of high school seniors had never used any alcohol, tobacco, marijuana, or other drugs. 3% in 1983. Last year, that number was 31%. Have never in their lifetimes, and 59% had not used any drugs in the last 30 days. That used to be 16%. And there's a racial aspect of that that's pretty interesting. The black kids are more likely to be abstinent than the white kids are. The difference there is 28% versus 37%. So it's something that's quite striking. What a large percentage of young black kids have no alcohol, no marijuana, no tobacco, or no other drugs. That's something to be particularly proud of. But I think for all races, to help kids grow up drug-free is a very important goal.
Indeed. Johnny, do you think of anything, top 2 or 3 things, folks outside of the profession? Go ahead.
Let me add one part of that that's really important to me, and that is the families and the people directly associated with people in recovery. They share somewhat in the illnesses sometimes, but they mostly share the ignorance that the most of the population has about the disease. And I know Robert Weiss, who's written a book called Pro-Dependence as opposed to Codependence. And his basic core is saying nobody can love stronger than parents and family. But when it comes to addiction, they don't seem to know how to use that love. And so teaching them how to use that love for a perspective way has a lot of outcomes. And one of them is it informs the community. And they become more anxious to talk to political leaders, everybody else. So in my clinic, we have Saturdays for families, and we have Zoom meetings right now. But people stay for years and years after their children or whatever have gone on and left DC or whatever. They stay with our group because they like to continue to be associated with the recovery side of this disease and let their own stories speak for themselves as parents. And so educating the family along with treating the individual is a very important thing. And of the 2 or 3 things, I think that's one I really much my emphasis on.
Yeah. Great. Dr. Duverney?
So I do work also with kids, and I agree. Again, that's my passion. Catching them early is important because oftentimes the children are dealing with adverse situations, even at a young age. So you think about the early traumatic experience that kids have and the potential of them, the increased potential they're using as a result. So I'm a believer in working with kids. I also do work with school-based mental health programs in the area, supporting the build out around not just mental health, but building out around the understanding of substance use. So it's just not about, you don't have to be in the profession to be an advocate. Learning and educating and sharing what you learn and being open to sharing what you learn and not holding it in. It's just as important as if you were the clinician. And I kind of walk both sides. If anyone knows me, you probably don't know I'm a clinician until I tell you, because I enjoy the conversation of information, that sharing what I know and passing it on at whatever point possible. So again, not necessarily being a clinician, but outside of that, being the greatest advocate and being willing to share and have those conversations and volunteering these communities to share the information, to be that link to the person who doesn't understand and to be that voice on behalf of that person that doesn't understand, to pass on that information in and around the communities.
Awesome. I'm going to take this. Go ahead, Johnny.
That is, politics is important to our field. A lot of legislation is created at the state level, national level. It's important to us. And we should be telling our own community that they have a voice, they should use it. And they start right at the local level in the neighborhood, because every guy running for office or a gal running for office goes door to door, has meetings, show up and just ask a question. What do you think about people who need help? Just asking that question repeatedly gets different people thinking different things. And so it's an important and easy thing to do on behalf of our disease.
Awesome. Thank you so much for sharing that. As we're getting near the end of this session, I want to encourage everybody, if you have a question, to go ahead and put it in the chat, or you can raise your hand at this time and we will, call on you so that you can ask our panelists a question. At this time, I'm going to introduce my co-host, my partner in crime for this expo. He's really been helping us out a lot, David Mays. He's one of our community outreach coordinators, and he has something he wanted to share with us.
Well, Chris, thanks. I just want to say something very brief. This particular panel means more to me than some of the others we've had because of the people that are on here. I heard the name Ron Clark mentioned, Dr. DuPont. I met you through Ron Clark. He was my boss back in the day. I'm in this field right now because of Ron Clark. It was the spring of 2008. I was just coming out of detox and I was sent to rep. Barack Obama was ascending to the presidency. And so I met Ron Clark at that time, and his impact on my life changed my life. And so I'm doing what I'm doing now because of him and people like Dr. DuPont and Johnny and Ron Clark. And there was a gentleman, my first boss when I came to DC in '81, was a guy named, I don't know if you guys know him, but he was my first boss, and Jim Vance, his sponsor when I first came in. That's why I mentioned his name. But I like to listen. When I hear what I'm hearing right now, it's incredibly powerful for me. And I just want to say that I feel tremendously honored to be here. I have no comments other than thank you guys so much for being here. We really are going to benefit from this long term. So I just want to say thank you. And Chris is going to wrap us out for the first day, but this has been an incredible day. Just simply an incredible day. We thank every one of you for participating.
Could I say one thing about that I think is really important for
Yes, sir.
Understand about recovery. And I think people who are in recovery need to talk about that a lot. And I think and also to get people to recognize people in their lives who are in recovery and ask them 3 questions. One is, what was your life like when you were using? What happened to get you to want to change, to stop using? And what's your life like now? Now, I have never heard one of those stories that didn't inspire me. Those are some of the most amazing stories, and everybody now has got somebody in their family, somebody they know who's in recovery. The more they can learn from the people in recovery about their stories, the better they're going to be able to prevent this problem and also help people get into recovery.
Well, if there's no other questions or comments, I want to thank everybody for coming out. We will begin tomorrow. This is not the end of the expo for us. Tomorrow, the first session is at 10 o'clock. We're going to be talking about, let me make sure I got it right. Is give me a second here. Day 2 for reducing stigma, co-occurring disorders, and harm reduction. And it's interesting enough, through the early panels, we talked about that reducing stigma a lot. I just kept hearing that theme come up. And like Dr. DuPont says, it was just like we need to be talking about it more and more. And I'm so glad we've been having these conversations. Thank you for all, everybody that's in the audience, that's on the panel, Ms. Walker, Thelma, Jamie, and everybody that's watching the recording right now. This has been awesome for us live. And we know that you're going to get a lot out of it when you come back to see this post the 20th. So I'll let Mark.
Well, we're going to post it on our website after this. So this will be ongoing. So we want everybody to, we want to thank everybody. We thank all our panelists. We appreciate your support. And, we thank you for helping us to inform the community about the work that we do and the work that's needed in the community to expand services, because we feel that this is an important issue that we need to expand recovery throughout the continuum and continue to doing the good work to help people in the community. Mm-hmm. Thank you so much.
Thank you.
And hope to have you back very, very soon.
Indeed.
Hey,
Okay,
thank you so much. We appreciate the hard work that you've done and the ground that you have paved for everybody, and that we can continue doing the good work that you've started.
Indeed.
I want to say thank you to everyone.
Take care.
Bye-bye.
All right now,
It's a privilege to be with you.